5, 4, 3, 2, 1. Let's go. Diary of a Kidney Warrior. Sharing faith, knowledge, hope, and love.
Hi and welcome to Diary of a Kidney Warrior podcast. My name is Dee Moore and I am a stage 4 kidney warrior. This podcast is dedicated to encourage, educate and inspire as we explore all aspects of kidney disease, chronic illnesses and health. If you have any questions or ideas for future topics you would like me to cover, please do get in touch with me on Instagram, Facebook and Twitter using the handle Diary of a Kidney Warrior. Today's episode is the third part in a 3-part series where we're taking an in-depth look at kidney disease with lead chronic kidney disease nurse Pat Simoyi. In part 1, we looked at what kidney disease is and what causes it. In part 2, we looked at how kidney disease is diagnosed and the signs and symptoms of kidney disease. And today in part 3, we're looking at different treatments for chronic kidney disease. Hi and welcome to Diary of a Kidney Warrior podcast. How are you doing today, Pat?
Very well, thank you, actually, Dee. And thank you very much for allowing me to come and talk to you again. I'm beginning to feel like I live here on your podcast. It is actually absolutely wonderful to just chat to you about something I've been involved in for the past 33 years. And I absolutely enjoy it.
Me too. It's been my honour and I've learned so much. In part 1, we talked about what kidney disease is and what causes it, and we talked in part 2 about diagnoses and signs and symptoms, and I know that there was so much in there that can help people and raise awareness. So thank you again so much for sharing so much knowledge and what I like to call gems with us. And today, yes, part 3, you're definitely a family member of the podcast now because, part 3, we're looking at different treatments for CKD or chronic kidney disease, for those who don't know what CKD stands for. So yes, I'm going to hand it over to you. And yes, what are the different treatments for chronic kidney disease?
It's wonderful. Thank you very much. I'm a nurse, and as you know, I'm a kidney nurse. And when you are a nurse, when you are talking, you almost like start from advising people about the obvious. Lifestyle changes. Exercise is good for the whole body, for the mind, and for the kidney too. So if you exercise, they say if you are mentally unwell or whatever, or you are feeling down, you feel happier and everything else. If you exercise, your blood pressure comes down, and that is good for the kidney. So lifestyle issues, if you stop smoking, that helps the kidney too, because it doesn't actually narrow the veins that go to supply your kidney as well. If you eat well, it also is good for the kidney because you don't choke the kidney with a lot of fat around it. All our organs are suspended in the body, and they're held up together by fat around them. So if you put too much fat around them, you actually choke them, and you find that they will suffer from that. So health style changes is very, very important. Now, what you eat, low salt stuff, we always say that. And I remember, if you remember, many of you, if you're as old as me, you remember the campaign about Sid the Slug, who, if he ate less salt, he would survive. And it was also encouraging us to actually eat less salt, because if you eat too much salt, you end up retaining water that you don't need in your body, which will make your blood pressure go up and which will actually also upset your kidneys. So lifestyle changes are very, very important. Stopping smoking, eating well, exercising. I can't emphasize that as a nurse. So I'll start there as a nurse. Now, what else do we need to do? What all other treatments do we give somebody with kidney problems? The very first thing is to make sure that whatever caused your kidneys to get damaged is controlled. Whether it be diabetes, you make sure that actually the treatments are robust and they're actually controlling your HbA1c or your kidney, your blood glucose to between 48 and 58, which are recommended guidelines. If it's high blood pressure, remember that caused your kidneys to get damaged. You also make sure that your blood pressure, if you are not diabetic and you are not losing protein, is below 140/80. And actually, if you also monitor it at home, you'll find that it will be better because you won't have those issues around white coat syndrome and everything else. So if you were worrying about what you'd get for Christmas this year, you can ask for a blood pressure machine. And the Hypertensive Society tends to prefer the Omron machine. Now, I'm not paid by these people, but that is what is recommended. So if you've got no protein and you're not diabetic, your blood pressure should be below 140/80. But if you've got protein in your urine and you are diabetic as well, we tend to want it to be much lower. Anything below 130/80 is fine. Now, we tend to worry about blood pressures when the top one gets below 100. Because if you have a very low blood pressure, it means the pressures are not good enough to pump blood to your organs. And if the kidney is ever starved of blood, of nutrients, of oxygen, it also gets damaged. This is why you find if you get dehydrated severely, whether we have a lot of diarrhea or you are just sweating so much, you are so unwell, you end up with kidney damage because there is less supply of oxygen, there's less supply of nutrients to the kidney itself for it to be able to do what it has to do. So we always say try to keep yourself hydrated properly because that actually also helps the kidney. Now, the poor hydration bit, you tend to find that in young children, you also tend to find that in people with chronic conditions. They say people with 5 tablets or more, who are taking 5 tablets or more, or people who are diabetic, or people who have just got a long-term condition, they are very much at risk of having kidney damage then. And to try and prevent that, because I come from a preventative side. I want you to prevent things. Yes, we're going to treat it if that something happens. You have to go in and have a drip of saline in the hospital, but you can prevent it by making sure that you are well hydrated. So whatever caused your kidneys to be damaged has to be managed and has to be right. If like vasculitis and things like that, different causes of kidney damage, they need to be followed up very, very closely to ensure that they are all controlled all the time. And if they are not, and you start feeling poorly, ring your unit and make sure that you're given more tablets or they find out what's going on with you, and then you can be treated so that you don't actually continue damaging your kidney. Now, the other thing while I'm on the vasculitis and everything else, a lot of people with vasculitis or even a lot of uncontrolled blood pressure, uncontrolled diabetes, they also tend to lose a lot of protein. Now, we all know that there's a lot of research now which shows that if you lose a lot of protein and that is not controlled by the medication tablets like Ramipril, the Pril tablets or the Irbesartan, the Sartan group, or also they called ACE inhibitors, those ones are, or angiotensin receptor blockers, and also the newer diabetic tablets, the SGLT2s, the canagliflozins, the dapagliflozins, the empagliflozins, the gliflozins. Those actually reduce the amount of protein loss. And I want you to remember as well that controlling your high blood pressure will also control the protein loss, and also controlling your diabetes also reduces the protein loss. So that is what we try to do. If you control the protein loss and you are put on these newer tablets, which also benefit the heart in other ways, because it actually makes the heart push out more blood as well if you've got heart failure, and or not only that, it is a vasodilator. It actually opens up your vessels so that you don't have things packing in your vessels and causing blockages. We tend to give that for that purpose with your statins. Some people actually who have had a few cardiac problems will also have some aspirin. So not only are we treating kidney disease, we are also preventing the potential problems, which are heart disease, which is what they call cardiovascular disease. So we are giving you the Preo tablets, the glufosine tablets, and the sartan tablets like irbesartan, ramipril, or empagliflozin, because we are also preventing future complications of heart disease. So just remember, because people come and say, "Oh, you give me some more tablets. What are they for?" I always say some tablets we give you now are almost like, those martial men at a carnival who keep the groups walking, moving. These tablets keep the blood moving. And with the exercise and everything else the lower salt intake and everything else that you are expected to do, you find that your vascular system is actually patent. The kidney is part of the vascular system because blood also goes in there and out through to be cleaned and out. So it's part of the vascular. You have the heart, you've got the kidney, so it all moves around. So just remember, we are not only treating the kidney, but we're also preventing potential problems. Now, I want you to remember all those functions of the kidney as well, that we are looking for them when we take all those buckets of blood tests that we take all the time. And I remember I have everybody going, "Not again." They don't want with their blood, but we have to find out. That's the only way we can find out whether your bones are healthy. We have to check your parathyroid hormone levels. We have to check that your phosphates are controlled. We have to check that your calcium is controlled, so that you don't have those aches and pains which you have. You are sitting down, you have aches and pains. You're standing up, you have aches and pains. You can't put yourself in any position to feel better. It's because sometimes when you don't have enough vitamin D, which the kidney is actually supposed to be responsible for processing, you end up having aches and pains. So we check that. If you need any treatment, we sometimes give you some phosphate binders, which you have to take with food. Remember, with food, because they work on the food that you are eating, like your we used to use calcium many years ago. I don't think we use it anymore now. There are newer ones now, like Fosex, Renagel, those tablets that actually bind the phosphate that is in your food and take it through you so that you don't absorb it because it's difficult to get rid of. And then we give you the parathyroid hormone tablet, which is your alpha calcidol, which suppresses the activity of the parathyroid gland, because if it's too active, it leaches calcium out of your bones back into the bloodstream, and you can end up with so much that it actually makes your vessels, it actually stashes it up around your vessels. They are like steel. You can't actually, they are inflexible. I remember many years ago when we used to use a lot of tablets which had calcium, a calcium base. There was a gentleman who was taken to theatre to have a kidney transplant, but they couldn't clamp his vessels to sew them onto the kidney vessels because they were too calcified. And if you also calcify your heart, you calcify your aorta, which takes blood out, then we start having problems. So we are checking for that all the time. So all those buckets of blood you leave with us, after you have gone, we are looking at them to make sure that these things are not happening, and changing your tablets and doing all sorts. And then some people decide not to take it. But we are trying to help and prevent complications, because if left alone again, it causes cardiovascular problems. And with an unworking heart, even a transplant won't be visible, because the person won't be suitable to go under general anesthetic and things like that. So we try to start it early, and where I work, where you're trying to identify those things early and manage them early, I'm hoping that by the time, if unfortunately they hit the dialysis place and they will need these things, they won't have those complications at all, because we started doing it very, very early, and that is not happening. Okay? So the bones, the anemia as well. I know all of you will end up on EPO, and some people are on it already. Some people are not on EPO already. EPO is supposed to be a beautiful, I have to say beautiful, don't I? Hormone that is produced by the kidney, and it produces it because there is less oxygen in the bloodstream. And the kidney actually is very clever. It senses that and says, let me produce some EPO to make your bone marrow produce more red cells. And then it makes you some red cells for you so that you can carry oxygen around and be able to run for the bus or the train or the tram. Nowadays, there are trams, aren't there? So if you haven't got enough red cells, you won't be, hemoglobin, they call it, you won't be able to have enough oxygen going around your body. So that is important for you. And if you have less as well, it damages your kidney, because the kidney, for it to function, it needs the oxygen to function. So we check again for anemia, make sure that you are not anemic, and we give you EPO. But we don't always start giving you EPO first. We start giving you all the ingredients that the body needs to make a red cell. When you are making a red cell, if you are Mr. Body or Mrs. Body and you're trying to make a red cell, you need some ingredients, like you're making a Victorian sandwich or like you're making a curry. You need your B12, you need your iron, you need your folic acid, you need also a body which is not infected, which has not got infections, which are upsetting things in there. So we check for all those things, and we always tend to find that people have got less iron in their body. So we give them IV iron and make sure that the iron is there for the body to use. Or we give them folic acid as well. Some people are on 3 monthly B12 injections, and I've never met anybody who likes it, but it has to be done. So that's what we do. That's why you end up on so many. And once all that in their right levels and the hemoglobin is still low, then we give you EPO. It's almost like you're sort of enhancing it. If you give the EPO and the either one of those ingredients is missing, it's almost like if I make a curry myself, I can never make it like my friend's mom who is Asian. I forget some of the ingredients. Like I remember, I always forget the garam masala or something, but it won't taste the same. But it will look like a curry, but it won't be as nice as. So my curry is never as nice, and the body will not use something which is not perfect. It wants a good red cell. So what then happens is either the cell will be too big or it will be too small because something is missing. Okay. And the spleen will crush it straight away because it thinks you have used it. So your body's making, and the spleen is crushing, and you are, and it's not benefiting anyone. So this is why we bring you for IV iron, and we ask you to take folic acid, we ask you to take some B12 injections. It's really because we want the ingredients to be right for the body to make a good red cell which carries blood and which will make you feel good. Your quality of life makes better because you can go and do what you need to do as a parent, as a husband, as a wife, as whoever you are in your family, because you've got the energy. Okay, and sense. Apart from the EPO, we also control your blood pressure. That's one of the symptoms of having a kidney which is not functioning. Now, the high blood pressure itself can cause kidney disease, but kidney disease itself causes high blood pressure. So sometimes some people's high blood pressure came because of kidney disease. I remember going to see someone and they said, actually, we need to treat your blood pressure. They said, oh, no, my grandmother had high blood pressure. My mom had high blood pressure. I have high blood pressure. You're never going to treat it. No, we've got better tablets now. We've got more powerful tablets, and we can do it. And we know that if we control it, it will not only preserve your kidney, it also preserves your heart. So we will always try to make sure that we control it to the recommended levels. Sometimes if somebody is losing protein, a lot of protein, we tend to even want it a bit lower. And just make sure that they are not feeling dizzy. Sometimes we bring it a bit lower, but not all the time, because we don't want you to fall down and break your neck or break your leg or whatever. We don't want you to do that. The other thing that we have to also treat is the water. If you are accumulating water in your body, then you carry so much. Your heart will have to work with so much volume, and with time, it just gives up. So like I said again, we put you on water tablets, and they have to be monitored, because if you are earlier on in your or even later on, if you have too much water tablets, you can actually dry yourself, and that will affect the kidney as well. So it needs to be monitored. It needs to be monitored very well. Just remember, a weight that has got to do with water normally is it jumps up over a few days, rather than I've been eating a lot of chips and I put on weight. You don't put it in a week. But fluid weight, you put it next day, you put it on, and you start swelling, because the body tries to snatch the water away from the heart, so that at least you can breathe and talk to people and do all sorts. So if you find you're swelling, and you also find that you are nicking your partner's pillow when you are sleeping, because you are feeling a bit breathless lying down, it could be some fluid. Talk to your unit, and they will put you on. They will safely put you on water tablets, because it has to be safe. And those are some of the tablets, actually, they need to be reviewed when you are very unwell. If you are very unwell and you're in the hospital and you can't drink and you can't eat, or you've got diarrhea, or you are septic, somebody needs to look at your tablets and make sure that you don't continue taking your water tablets when you are so poorly and you're not drinking. You don't take your blood pressure tablets when you are so unwell and you're not eating either. So those things need to be reviewed sometimes. Even in COVID as well. I remember I had COVID, and a GP friend was saying, "Are you still taking your blood pressure tablets?" And I'm thinking, no. So those things need to be reviewed when you are poorly with something else, because they may end up worsening the situation, because whatever situation they were put in for is not relevant at that time. Right. It's not there at that time, because you've got something else. And like, for example, if you are got diarrhea, you become dehydrated. So if you take more water tablets, you end up with nothing in your body, and you end up in trouble. So we don't want to do that. So just remember that. So I said blood pressure, I said the bones, I said anemia, and I said volume. And sometimes as well, if you are becoming too acidotic, there are times, because the kidney gets rid of waste, and by getting rid of that waste, it maintains your body at a right pH for it. So what happens sometimes, because when the waste is accumulating and you got so much water and everything is going on in your body, your pH goes down. You become acidotic. And we sometimes have to give you some bicarbonate of soda. And we monitor that too. Whatever we give you, we monitor. Okay? And so there are some tablets as well which are got rid of by the kidney. If it's ourselves, like things like digoxin, things like lithium levels and things like that, because they are got rid of by the kidney, we tend to monitor them. And sometimes we reduce the dosages and things like that. This is why we always ask you to bring your tablet list with you when you come to clinic. I have been told, Pat, I brought it last month. And I'm thinking, yes, I know you brought it last month. I still want to say it. In case somebody has prescribed you something that is got rid of by the kidney and the dosage is not right, we still need to see that. And we just need to see it. I'm sorry. When I ring sometimes, I'm thinking, can I listen to you? Can I have your tablet list? So, but I gave you again. I said, yeah, I know. I just want to pick up on what you are taking. Plus also, don't be in a habit. Just go and buy things from the counter. Because if they are got rid of by the kidney from the body, and you still take the dosage that you are normally taking when the kidneys are fine, we can get into trouble too.
So are you talking about over-the-counter supplements? Like, what did you mean?
Yes. I'm talking about those tablets like magnesium trisilicate, or something that you can just go to the pharmacist and just say, can I have that from, I've got antacid or whatever. Not only have they got a calcium base. So if you've got calcium problems with your bones, you end up calcifying your own cells.
Wow. Okay.
Yes. We just need to have a look at them and talk about them. And also, we tend to talk about some of the teas that you have, the slimming teas, and I don't know where they are from, those teas that we take. Some of them are quite dangerous. They damage your kidneys. So be careful what you take over the counter. Yes, it may be all right to know somebody else. If you want to start on something out there, go and discuss it with your renal team. They will tell you what to do. Okay? So when we are treating kidneys, earlier on, we treat blood pressure, we treat anemia, we treat the underlying cause. We make sure that we monitor the function of the kidney. Is it working? If it's not, how can we help it? And we continue doing that. And we chop and change, because we never can be as efficient as the kidney. We chop and change. You come in, we say, oh, take so much. And when you come back, we say, oh, no, stop. Take this one. And then, because we are trying by all means to mimic what the kidney does. We haven't got there yet, but we try our best. If we work together, it normally works. It's like people who then just go home and they put things in the bag and never take them out afterwards, who have problems. But anyway, so what happens is we'll get to a point where I remember yesterday I was talking to a gentleman who was on furosemide 500 milligrams. He said, I'm on a big dose. I said, what big dose? He said, big dose. I said, what? He said, of the water tablet. I said, let's say. And he told me, I said, oh, no wonder why you were saying big dose. Because that's almost like the final dose. It's because we're getting that point where the kidney is not responding anymore. And when you get to that, some people they fill up with water and feel very breathless. Some people just feel like they have got a cold, which gets worse by the day. Like if you got a cold, in 3 days' time, you start sort of like feeling a bit better, unless it's corona. You feel a bit better and better and better. With this one, you just feel more unwell and more unwell and more unwell and more unwell. Rather than then have an ambulance, it's on your unit, because all we do is say, oh, go to a GP and have a blood test. A blood test will tell us what's happening. And then you can go by the choice that you have made. And all I'm saying is, when I used to give people the pre-dialysis counseling, I used to go in and say, oh, I've come to discuss about the options after the tablets have got to a point where they're not as effective. Because we can control blood pressure, we can control the weight, water-wise to a point. We can try to control the bonds. We can try by all means, but we cannot change the creatinine levels. They are still accumulating. We cannot change the urea levels. They are still accumulating. Plus, also the water may need to be taken out for the person to feel better.
Can you explain for our listeners what is creatinine and what is urea?
Urea, yeah. Creatinine is actually a waste product of what we eat. Creatinine is actually a waste product of our muscle activity. The more muscular you are, the more creatinine you produce. So if you were to take me and you Dee, I would produce more protein because more creatinine. Sorry, because if you took this as muscle, Dee, and not fat, I'll be very muscular, and I'll be. For example, let's say myself and Eubank Jr. I know there's Eubank Jr. now, who's a boxer, isn't he?
Yeah.
Because he's got more muscle than I do, he would produce more creatinine than me. Okay. Because actually, they tend to say as you get older and as you get fatter, you replace your muscle with fat. So you won't produce as much muscle. So, for example, if Eubank Jr. had a creatinine of, let's say, 150, he's fine. But if I had a creatinine of 150 and the way I am, by the way, listeners, I'm a little bit on the higher side of I'm obese. I'm actually fairly obese. So this is why I'm giving myself an example, because I've replaced most of my muscle with fat. So what you find is, although I'm not producing as much creatinine, I'm in trouble because I don't have the muscle. This is why actually we use GFRs, because you have to, if you had to estimate somebody's kidney function, you have to look at, are they wheelchair bound? Are they big? Are they small? Are they black? Are they white? You know what I mean?
Yeah.
So GFRs tend to actually stop you thinking about who it is, because it takes that all into account. So creatinine is a waste of muscle activity. Urea is a waste of what we eat as protein. We eat things as protein, and the waste is urea. We used to restrict people on the amount of protein they take many, many years ago. And I remember we used to end up with very anorexic people because all the food without protein was nasty. So I know that we don't restrict protein. You eat the normal protein and stay healthy, but we sort of monitor what's going on then. So that's the difference. So remember, creatinine is to do with your muscles, and if you are big muscle-wise, you will produce more. If you are big fat-wise, you don't produce as much creatinine because it's fat you are carrying rather than muscle. So that is what those two are. So you can't get rid of that urea and creatinine using tablets. You have to dialyze them out. And when we tend to get to those places, areas like GFR of about 20, we will want to sit people down and say, you know what, we're getting to that point where we just need to talk about things. You need to think about things when your mind is not unwell. With urea or anything. Let's sit down and tell you that, there are different ways of managing you when we get to that point where the tablets are not being as effective as they should be. We will need to put you on dialysis, or we will need to transplant you. I will start off with the transplant. This is when somebody either gives you a kidney from the family is live, or somebody with emotional ties with you gives you a kidney, or somebody from the street offers to give the unit a kidney, and you're one of those who, depending on whatever system that your unit does, offers you that kidney, you can then have a transplant. That is if you match their kidney. And many years ago, when you used to sort of like look at matching, what matching means. It's not, sometimes people used to think that you will have a little piece of flesh taken and another little piece of flesh taken from someone and look at it. No, they just take blood tests and they look at your genetic makeup. And if you match the person, then they'll give you that kidney. So, like I said, different ways. Either somebody dies they're diagnosed brain dead in intensive care, and the family or the patient wish to give somebody a kidney. But nowadays, it's supposed to have changed now, isn't it? That everybody is assumed to want to give your kidney until they opt out. I don't know how far that has gone, but you can find out with your kidney units to make sure that you know exactly where you are. But they have to match you, and if you match that kidney, they give you. But you shouldn't be having any infections or things like that during that time, because the powerful drugs that they'll give you after a transplant, if you are given them when you are not very well, especially infection-wise, that infection can just be, it's very big and can actually affect your life, really. The other thing as well, I remember the last time I read about it and I talked about it with someone. If you have had a diagnosis of cancer somewhere, and it's within 5 years of that diagnosis, and it hasn't recurred, but it's within, and nobody has sort of checked you, like scanned you to make sure that there was nothing in your body, you would not get that, because they want to make sure it is after 5 years and you are clear that they will consider you. The other thing they have to consider as well is your heart as well. You have to have heart tests and things like that. This is why we need to early manage it much, much earlier. and make sure that things are done, so that when that time comes, if you are that one of those people who end up on needing dialysis, at least your heart is in the right shape and right health to have a general anesthetic. So that is one, and that can actually be done well before somebody gets dialyzed and things like that. And they tend to say the live related transplantation, a transplant that you get from someone who is alive, is a much better quality, because that person hasn't been in intensive care where they have all these drugs and things like that given to them. So they tend to say that is the best one. But I've seen people who have done really well with their transplant that they got from somebody who was deemed brain dead in intensive care. And just remember, because I have this question all the time, people ask me if there's been a disaster somewhere, why can't they take those people who died and transplant them? It's really because that kidney has to be perfused. If you leave a kidney without any perfusion, by perfusion, I'm sort of saying water going through it and sort of make sure that it's safe. The tissues are kept alive. The tissues just die very quickly, and so you can't actually bring a dead person in and get their kidney from them. You can't. So anyway, I don't know what other research is happening at the moment. But I haven't done sort of transplants in the last 2 years, so I don't know what research is happening. So go and ask your renal units, and if they understand, they know that you understand and you are keen to hear about it, they will be very happy to talk to you about it. So the other option is dialysis. There are two types of dialysis. There's the hemodialysis, which we used to always call the blood dialysis, or there's the peritoneal dialysis, which is the fluid dialysis. Now I'll start off with the blood dialysis. Blood dialysis is when we take blood out of you, put it through a machine, and the machine cleans the blood, and the machine warms it up nicely so that you are not cold when you finish, and it actually makes sure that there are no clots or anything that come out, and the machine puts it right back into your arm again, so that it goes through your circulation and do what it's good at. That takes about 4 hours or more, 3 times a week. In some units, especially I know that the ones abroad, people can't afford to have 3, they have 2, but then the quality of their life is not as good. But in England, I know that we do 3 times a week. It could be a Monday, Wednesday, and Friday, which are the more popular days, because people don't want to come in on a Saturday. So there's always like, do I have to on a Saturday? But anyway, there's Tuesday, Thursday, and Saturday, which are not as popular, but somebody has to dialyze on there. And don't forget, you can't just create a dialysis space like that. So you need to work with your nurses, actually, if one has to go there. But if you've got the days that you prefer, you can just sort of say, but I really prefer this, so that if somebody goes to a transplant or get transplanted or whatever, you can actually be moved into that space there. And I remember when I used to work in dialysis, we never used to have any problems. But then if you sort of keep on insisting, like for asking for somebody that you know is not there, which they can't just make like that, then it just becomes very stressful for everybody. But anyway, I know that you are all very good, and I don't want you to go to dialysis, so take your tablets. Okay, so you can have dialysis in the hospital center. You can have dialysis in a satellite unit, which is almost like a unit which is not very far from the hospital. Yeah, some people dialyze at home, and that is called home hemodialysis. And what the nurses do is they train you everything to do with dialysis, at the machine, how to do your blood tests, how to collect them, and how to do your blood pressures, when to phone when you need to phone, and you are given a phone, and everything else. Any costs around that are picked up by the hospital. And in my last job, I used to go around the patients I worked with, and we used to have fun. I used to have my cake. We used to discuss everything to do with dialysis, their condition, anything they wanted. And you found that 6 months of doing that, they became so knowledgeable about their treatments. And I used to have one person who used to go and dialyze abroad. They thought he was a doctor because he used to come in and say, haha, they all thought I was a doctor. And I said, I hope you didn't do any clinics. But he didn't do that. But that is a way, again, of getting involved in your care. And you can choose the time that you want to do it. You have your machine in your house. So if you do not want to do it this evening, you can do it this morning. Something you can't do in the hospital, it was flexible. I know actually that there's also night dialysis, nocturnal dialysis, where somebody puts themselves on the dialysis at night. And that, again, the nitty-gritty, you actually have to check with your units, how they're doing it, how you go onto it. They've got some criteria that they actually use. But I just wanted you to know that there's hemodialysis, and there are different options of it. And then there's peritoneal dialysis, which is actually putting a tube inside your tummy. You can still digest your food. You can still have a love life. You can still do what you need to do. This tube goes in between your in a membrane. There's a membrane in your tummy which covers all the intestines and everything else and pins them down so that they're not bobbing around and causing any problems. Now that membrane is doubled so that it does the job properly. Somebody discovered if you put the tube in there and you put fluid in there, that fluid will make an area of less waste in the body, and the body will try to make it such that it's got as much waste as it does. So it lets in some waste from itself, from the blood vessels which are around the tummy there. And by so doing, if you then, after 4 hours, drain that fluid out and put some more, the body still tries to make it the same the same amount of waste as it does. It's called diffusion. Those people who remember the science, diffusion, movement of particles from an area of higher concentration to an area of lower concentration across a permeable membrane. That membrane is called the peritoneum membrane, which is there, which actually holds everything down. But that works as a diffusion membrane, and you lose your waste that way. There are ways of increasing the water loss as well, which the units will tell you about. But that is another one. And there are different forms of it. But what happens inside the body is exactly the same. So you can do it in the day, 4 times a day, or you can do it at night with a machine, which is automated peritoneal dialysis, or you can do it with a machine for all the people with dexterity problems or whatever, being assisted by someone else to be connected on the machine and back. So, but what happens inside your body is exactly the same. That dialysis works by diffusion, movement of particles from the body where there's too much of it into where the fluid you've just put in, which is inside like a membrane, which the surgeons actually sort of make when they take you to put the catheter in, and you actually dialyze that way. Now they tend to say if you start on that one, it buys you time before you touch your areas where you can put fistula in. So you can do that for, let's say, 2 years or so, and hopefully you get a transplant. So we haven't touched any of your fistula size, because for hemodialysis, you will need somewhere to get the blood from, which is called a fistula, a dialysis fistula. You always have to say dialysis fistula because there are other fistulas as well. Fistula means an abnormal connection between two organs normally. But if it's a dialysis fistula, it means a communication between your artery and your vein in your arm or your leg or where they put it. And what that does is the artery, because it's at a higher pressure, will pour its blood into the vein, and the vein will just get bigger and make it easier for the nurses to put needles in. Now, you can't use it straight away, so it needs to be made up 6 months or so before. But then we don't know exactly whether it's going to be 6 months or before, so we try by all means to just make sure that you have one. Somebody has one before they have to start dialysis, if the choice is theirs. So I remember my job was to go around and actually sort of give a bit more information around, depending on the unit I am from, around all those treatment options, transplantation, the hemodialysis and peritoneal dialysis. And I also used to give conservative management, where people can also make a choice of not having the dialysis or not having the transplant if they feel they don't want to. And as long as it's an informed decision, which is not made under duress, which is not made because somebody has got a lot of debt or somebody is not getting on with their family or something, something else, it is taken seriously. Where it is questioned, where somebody thinks, I don't know whether that is really, they're not just saying that because they're depressed. Sometimes people can be sent to a psychologist or someone to talk to them. And then whatever people talk about there, it doesn't get to the unit. If you cast, but that person still come back and say, you know what, I really don't want to. And that's fine. We don't force people to do it. Then also people need to know, because some people use that, especially when some people are saying, I think you are going to need a fistula now. They also say, I want conservative management, just because they don't want anyone to touch them. Then when they feel very unwell, say, no, I want to be, it needs preparation. People who are not prepared, people who don't have fistula and things like that, when they end up putting lines in, can have infections and things like that, it just puts that person at risk. The outcomes of somebody who is not prepared are not as good. This is why we try to make sure that we start the dialysis, we start the preparations much, much earlier, even before the dialysis is needed. Plus also, if somebody wants to be transplanted, then we can start doing the process, because people need to have their tissue typing done, taking bloods. The donor, most of the time, if they are a live donor, they need to go and see a psychologist to make sure that they're doing it really. They're not being forced to do it. They're not being put under pressure to give they're doing it because they actually it's a gift to this person. It's not something that they're going to do because they want some money or they want favors from you or they want anything. It is a gift. So it is very important that things are put into place properly. And plus also we've got guidelines that we go by, nice guidelines, which tell us that, if your unit is doing well, that person should have a fistula 6 months before they come into dialysis. That person should have been prepared. Their hemoglobin should be so-and-so. Their PTH should be, we will actually have those. We have to send that to the National Audit Center for Kidneys every single month. And if you're doing unwell, if you're doing badly, you are shown that you're doing badly. So we have those to also make sure that we don't put patients at risk. So the treatments are lifestyles, taking your blood pressure, taking your tablets, ensuring that you live healthy, and also getting your information. Attending clinics is very important, because that's where we know whether we are doing it right or we are doing it wrong, and we rectify things. Like I told you, we try to do what the kidney does, and we try to do it to our best. But we can only do that if the person also comes in. And most of the things the patient has to do when they go home, most of the things that we say, go and do this, the person has to go and do them at home. If people don't understand things, they don't always do them. If you don't, find out. The units, there are people who actually just go and teach people on their condition at home. Talk to them. They will tell you what to do. Plus also coming to your podcast as well. Get some information from there. And use it to your benefit. Remember, not only are we treating kidney disease, we are also trying to prevent the complications of heart disease.
Thank you so much.
So I think I'll stop here for today, or else I'll continue.
Thank you so much. That was really, really interesting, really, really helpful to know all the different options and why. I think it can be really difficult as a patient when you're given, this tablet and that tablet, and you're wondering, why. It really has opened up my eyes, because there's tablets that I personally was given and I was like, why am I taking this kind of thing? And I don't want to be on another medication. I don't have to take another tablet, this, that, and the other. But understanding that it's like a jigsaw kind of thing. Yeah. All the pieces need to be in the jigsaw together for you to see the full picture and for it to work. So it really makes sense. what you're saying, and especially to do with the protein loss and the blood pressure and knowing that these tablets, are preventing things from getting worse. And it all makes perfect sense. So thank you so much again for coming and sharing with us so much gems. Like, that's my favorite word, gems. Sorry people if I keep saying the word gems, but I just think when I use the word gems, I mean something that is precious. This is really precious and so important information, and I really believe that knowledge is power, and the more knowledge we have, the more empowered we are to help ourselves, because as I keep saying time and time again, prevention is better than cure. And if we can prevent ourselves, getting worse in our kidney function and losing function, then that is so much easier than trying to cure the problem afterwards. So I thank you so much for sharing.
You are most welcome. Thank you.
Thank you for listening to Diary of a Kidney Warrior podcast. And don't forget that you can contact me on Instagram, Facebook and Twitter using the handle Diary of a Kidney Warrior. Please do subscribe to the podcast, and please do tell a friend. New episodes of this podcast are uploaded every other Monday. Until next time, take care and choose to live.
Diary of a Kidney Warrior, sharing faith, knowledge, hope, and love.